department. So people will join us step by step. Okay, so I think you know me, all of you, Char Rodriguez, director of the FMER, and it's a pleasure to welcome you to this first FMER webinar of the current academic year. And it's a very special webinar because our guest speaker is the 2022-2023 Pierre Pluye International Award recipient from Indonesia. So, as you know, Dr. Pluye was full professor in the department, founding member of the FMER. We created this award to honor and to recognize the huge contribution that he has made to the advancement of the mixed methods field of inquiry and its application in family medicine and primary care. And now, but he always be with us, but this annual award will always maintain his memory alive among us. So, and because of the name of the prize, I think nobody better than one of his former PhD, master's and PhD student, Rim El Sharif, who will be facilitating this webinar. So, Rim, the Zoom floor is yours. Okay.
Thank you, Chara. Welcome, everyone. So I'll provide a brief introduction to Dr. Fitriana, and then I'll let her go ahead with her excellent presentation. So Dr. Fitriana Mawardi is an MD with a doctoral degree in family medicine and primary care from the Pajajaran University in Indonesia. Her research interests are interprofessional education and collaborative practice, focused in primary health care, family and community medicine, geriatric medicine, and disaster medicine. She's now working as the head of the Primary Healthcare and Hemodialysis Center of the Indonesian Red Cross of the Yogyakarta Province region, and is research lecturer in the Faculty of Community and Family Medicine at Gadjah Mada University. So as Chara mentioned, so she's the recipient of the first Pierre Pluye International Award, and today she will be presenting her work titled "The Role of Interprofessional Collaborative Practice Among Primary Healthcare Providers and Malnutrition in the Elderly." After her presentation, we will have some time at the end for questions, and everyone's welcome to leave their questions in the chat as well. I'll be monitoring the chat. And this session is recorded and will be available shortly after the presentation. So thank you again, Dr. Fitriana. I'll let you go ahead with your presentation.
Okay, just I will start my presentation. Let me share the screen.
Yes.
Sorry. Well, thank you for the time to present my dissertation, and this is about the role of interprofessional collaborative practice among primary healthcare provider in malnutrition older adult. And this is the background why I take this topic, because there is sharp increase in the number of the elderly, and it's about 2050, and it will be increased threefold and reach 1.5 billion. And because of the high elderly population, so it will be make the potential to influence health-related spending in the need for comprehensive care will increase. And because of that, the elderly people need team-based interprofessional care, health services based on their interprofessional collaboration. And however, this is in contrast to the reality, especially in primary health services, where the difficulty of access to health management in collaborative interprofessional manner is the shortcoming in the service support in primary health. And collaborating using IPCP for health workers can be achieved through direct learning, development, and implementation. Collaboration using IPCP for health workers can be achieved through direct learning, development, and implementation, and will provide optimal results through family involvement. And the novelty of this study is the IPCP intervention is through Fitri's fourth step in developing primary health care's interprofessional collaboration. And the objective of this research is to analyze the competence of individual workers in primary care regarding IPCP in malnourished elderly, and analyzing differences in nutritional status in elderly with malnutrition before and after being treated through IPCP collaboration by health workers in primary care, exploring the experiences of elderly people with malnutrition who are handled collaboratively, and exploring family experiences. And the methods of this study is use an explanatory sequential mixed method design. And this combination method is believed to make it easier for researchers to reveal aspects that will be research targets and obtain complete, valid, reliable, and objective data and information. The weakness in both quantitative and qualitative methods can be minimized. And the quantitative data is collected first, then analyzed, and followed by collecting qualitative data, where the result will be used to support quantitative data. And the priority of this method is a quantitative research. And the quantitative design, we using quasi-experimental untreated control group design with dependent pretest and post-test sample. And we use one intervention group and one control group with both getting pretest and post-test. And the qualitative design with a phenomenological approach, and qualitative data collected through in-depth interview. And the sampling technique used in this research is proportional sampling. The sample population in this study was all primary health center in Puskesmas in Sleman Regency. Puskesmas is a primary healthcare services. And then the requirements that must be met in determining the sample by proportional sampling based on specific characteristic in inclusion and exclusion criteria. The sample in this study consisted of two kinds, namely quantitative and qualitative research samples. And this is for the inclusion criteria for the sample of the health workers, for the participants, and who including for the primary healthcare providers is doctor, dentist, nutritionists, nurses, pharmacists, and they work at the primary healthcare in the research location and have at least 2 years of work experience in the primary health services. And for the exclusion criteria for the sample of health workers, when they're not attending all learning programs and IPCP implementation. And for the inclusion criteria for the sample of elderly people in quantitative research, elderly people who age 60 years or over and living in the study area, living with family and having malnutrition problem. And for the exclusion criteria for the sample of elderly people in quantitative research, when they refuse to become participant, live in the nursing home, had 2 or more health problems, and had uncontrolled health problems. And this is for the inclusion criteria for the sample elderly people in qualitative research, and senior age 60 years or more, and live in the research area, live with family, and have malnutrition problems, receive implementation for primary healthcare workers, and can communicate actively, speak Indonesian or Japanese. And for the exclusion, who refuse to become participant. And for the family, who in a inclusion criteria is family related by blood or marriage to the elderly and live with the elderly for at least 1 year and participate in the implementation with health workers. And for the exclusion criteria for the sample of elderly family is refused to become a participant. And this is for the research work. The primary healthcare workers in the intervention group receive the training on IPCP. And the training with the step in the IPCP intervention are called Fitri 4 step in developing primary health care interprofessional collaborative, which stand for formation, introduction, training, and implementation. And this is for the learning objective, learning method, and learning activities for the formation. And this is the role for the healthcare provider. The doctor filled in the MNI and review medical history, analyzing of the result, examination of vital signs, anthropometry, and physical examination, collaboration with other health provider, and motivation for family involvement in the management of elderly with malnutrition. And for the dentist, filled in the MNA, and assess oral health problem, education related to maintaining oral health, and give suggestion for dental filling. And this is for the role in nurse, fill the MNA and assess the patient's socioeconomic changes, vital sign measurement, encouraging families to be involved in caring for the elderly with malnutrition, assist families in modifying diets, and for the dietitian, they assess the patient dietary habits, anthropometry measurement, educated how to prepare and serve interesting food, educated regarding daily energy need in the elderly with malnutrition, and for the pharmacist, fill in the MNR2 and assess the routine medicine taken if any, and educated for taking medication regularly, educated if there are drugs that affect the absorption of the nutrients. And the second step in the introduction, researcher provide an overview of the IPCP implemented to health workers in primary care. And this is the pretest. The participant did the pretest, used iCard instrument, and before training through the near-pod application and interactive lectures, the speakers came from various interprofessional background, including doctor, nurse, dietitian, pharmacist, and clinician who concerned in IPCP. The topic of interactive lectures are aging process, the role of each profession in treating elderly with malnutrition, and IPCP in primary and clinical services. And case study, after the interactive lecture, the respondents enter each breakout room in the Zoom meeting application, conducted discussion about case study that solved through IPCP approach. And the presentation, the respondent conducted wrote the result through a collaborative approach on the near-pod application and present the results of the discussion. And then after that, the respondent get feedback from the facilitator that gives suggestion related to IPCP for solving the case study. And the respondent take the first post-test used iCard after training through the near-pod application. And this is the display of the near-pod application. And this is the implementation, who health workers from different professions collectively measure nutritional status using MNA before intervention. And then they together make a home visit to malnourished elderly. And then the health workers provide intervention through IPCP, referral to primary health care was conducted if needed. And then the family continues the intervention talk by the primary care provider in collaboration with the IPCP for 3 weeks. And then the health workers with the IPCP collaboration conduct the monitoring. And the last is they make some evaluation. And this is the picture of home visit activity of IPCP team. And this is the elderly with malnutrition who need further intervention was referred to primary health care. And the control group in this research conduct the implementation of for elderly people with malnutrition who live in the work area of each puskesmas according to the standard at each puskesmas. And they do some standard counseling regarding to the health of the elderly, providing additional food, nutrition counseling. And all control group respondents will complete the pre-test before doing standard intervention on the elderly and post-test after a standard intervention. And this is the quantitative data analysis. We do psychometric evaluation of each item in ICAR and MNA using a RAS model, which allows for investigation of many aspects of a measure. And this include the response format, the fit of individual items and response, dimensionality, local independence testing, and the use of right maps. Each row score based on the measurement will transform into a RAS score. And the mean-width test is used if the data is not normally distributed to describe the comparison between two unpaired groups between before and after the intervention. And the researchers use qualitative analysis using content analysis and through inductive process. As you should know that an inductive process will make the research team better understand the data obtained to identify themes in the data, and the qualitative data collected through regarded in-depth interviews entered in a transcript and compiled into several codes by the coder, and the code from the analysis result will be analyzed to look for relationship between the categories being tested to produce a theme. And the researchers have trained coders to compile codes based on interview transcript. And the researchers will be involved coders in this study for the data triangulation process to improve data quality and for the reducing the bias. And the coders consist of two people with qualification of health workers from two different professions, doctor and nurses, and who have the latest bachelor and professional education and understand the coding process. And the researcher will compile the interview transcripts, and then the coders will read the entire document at least twice to identify pattern of experiences in the elderly. And the coder does the coding and filling in the result of the analysis on the coding form. Coder meet with researchers to group the topic, obtain into categories, and identify themes. And the meetings will be repeated until the researcher and coder obtained saturated data. And this is the data transformation from the score of ICAR and MNA, and the data correlation and comparison, including comparison quantitative and qualitative data, and analysis for conclusion of qualitative and quantitative data, and using aspect of the analytical framework from quantitative supported by qualitative data. And for the result and discussion, this is for the data of IPCP competency of primary healthcare provider for the age and gender and profession participant, because there is 50 participants were involved in the study who were divided into the control and intervention group, and each group consisted of 5 primary health providers who are from 5 different professions as representatives from each primary healthcare center. And the majority of the participants in both groups were in the age range of 40 till 49 years old and mostly female. And this is the participant in the control group had working experience for 2 till 3 years and more than 5 years. And most of the participants of the intervention group had working experience more than 5 years. And most of the participants have the degree level of bachelor with clinical profession degree. And this is for the results, so that there was improvement in the average ICAR scores between the pre-test and post-test in both groups. And the Wilcoxon sign rank test indicated that there was no significant difference between the pre and post-test in the control group. In the intervention group, the second post-test ICAR scores were significantly higher than the first post-test ICAR score after training, and were significantly higher than the pre-test scores before implementation. And we can see the significance in each IPCP domain. We conducted significance tests for every domain in IPCP based on the post-test scores. The results showed that the post-test scores of the control group in every IPCP domain were significantly lower than the intervention group. And this is the stacking analysis after online training, and based on the stacking analysis, a total of 22 respondents had IPCP competencies improvement in cognitive ability after they participated in the online IPCP training, while 2 respondents had decreased competencies and 1 respondent did not change in competencies. And this is the stacking on the pre-test and second post-test. The stacking analysis of pre-test and second post-test demonstrated trends of improvement that indicated most of the respondents, 23 respondents, had a significant improvement of the IPCP in competencies after implementation of the IPCP training. 1 respondent had decreased competencies and another respondent had no change of IPCP competencies. And this is the ranking analysis of the pre-test, first post-test and the second post-test. And this shows that there were negative changes in location in all of the IPCP item domains, indicating that respondents understand more and have more IPCP competencies at the end of the training than at the beginning about the topic addressed by that item. Overall, the primary healthcare providers' competence in IPCP was greater at the conclusion of the unit than before it. And this is for the nutritional status of older adults with malnutrition. There were a total of 40 older adults with malnutrition divided into the control and intervention groups who were involved to the end of in this study, and there were none of the older adults who were lost to follow up. More than half of the participants in both groups were female, and with a range age of 60 to 69 years. In the control group with 60 to 69 and 70 to 79 years in the intervention group. And most of the participants in both groups had daily activity in their home, and most of the participants in the control group did not have a degree, and while most in the intervention group had elementary degree. And this is for the comparison of the MNR score. And we can see together that the result of the Wilcoxon test showed that there was no statistical difference of the nutritional status between pre and post implementation in the control group. And in intervention group, there was a significant statistical difference between pre and post implementation based on the MNR score, with higher mean score in the post-implementation results. It means there was an improvement of nutritional status after the implementation of IPCP in the intervention group. And we further analyzed the MNA score in the post-implementation scores, and the results showed that there was significant difference between control and intervention group, with the higher mean score in the intervention group. From this result, we can assume that the IPCP implementation was better to improve nutritional status than usual care. And this implementation could significantly improve the nutritional status in the intervention group. And we conducted the ANOVA test to determine how strong was the IPCP impact on the nutritional status in elderly with malnutrition. Based on the ANOVA test, there was significant correlation between IPCP and nutritional status. And this with the correlation score is 0.674. It's very strong, and the IPCP contributes an effect of 45.42%. And this nutritional status in older adult with malnutrition. And this is the experience of older adult with malnutrition and their families. We can see that malnutrition is one of the nutritional problems that needs comprehensive care. And however, there is a gap between the expectation and the reality in collaborative practice in primary health care. The IPCP training improve the competency of collaboration to provide comprehensive care. Primary health care provides realize the needs of collaboration with other professions. We're able to better understand the roles of each other profession and share in the collaborative responsibility. And this is the experience of older adults with malnutrition and their family. Communication with other healthcare professionals is very essential, and the communication effective of healthcare providers was necessary in ensuring the elderly people care was comprehensive and involving them into healthcare consideration. And this is the result of the qualitative study support the quantitative findings. The phenomenological approach of the interview data resulted in the development of three main themes: IPCP provide comprehensive care and improve the patient health provider communication and empowers knowledge change. And this is the integration of the quantitative and qualitative results. The qualitative data were based on the experience, and the quantitative data were able to measure IPCP competence, and this was supported with the experienced elderly people. And this finding of this study shows that intervention 54 step in developing primary health care in professional collaborative met the IPCP competencies in all of domain, and this suggests that IPCP course named Fitri's 4 step in developing primary health care in professional collaborative can be effective in fostering IPCP competencies. And no participants were lost to follow up, and group allocation was not random. However, the process of allocating participants to a group was completely independent and can involve a wider population and identify the impact of IPCP learning based on each activity, such as assessment, physical examination, diagnosis, intervention, and implementation. Thank you for the time which given to me, and I will give this time to Rim. Thank you.
Thank you, Dr. Fitriana. This was an excellent presentation. What a great project. I'm going to open up the floor for questions.
Maybe, Dr. Fitriana, you could stop sharing the screen?
Okay.
Okay, thank you. Much better.
Sorry. Yeah.
Dr. Calcroft, if you want to unmute yourself.
Yes, thank you very much. Thank you for it. Was a very interesting presentation. I enjoyed it very much. Thank you. My voice is a bit croaky. I apologize. I wanted to ask you, it's great that you have the doctor, the dentist, the nurse, the dietitian, and the pharmacist all visiting the household. I'm just wondering if in practice that they would all be available to work together like that, and I'm wondering if there are situations where patients, elderly people, wouldn't be able to have access to all of those workers. It's great if they're all available, but I wonder if there are situations where they may not be all available.
Yeah. Thank you for your question. Yeah, it's a really in a practice, is it possible to collaborate in the primary care? This is the available. So because the collaboration in a primary health care is really important, especially for the elderly. When in primary health care in Indonesia, we have actually not only 5 professions, but in primary healthcare services we have a psychologists, and actually that someday that I can as including the psychologists in my research, but not all primary healthcare services have the psychologists. So in Indonesia, primary care involve many professions. After the training, they understand and the need of the collaboration. So after they got the training, and they realize to have the quality of to have a high quality of the services, it's can achieve through the collaboration like that. And we also involve a district officer to support the collaboration. So it's possible in practice.
But can I ask one follow-up? I mean, so does everybody have access to a practice that is fully staffed and has all of these people?
Yes. Yes.
That's fantastic. That's amazing.
Yes. Yes, they have the access. They have the access.
We're just jealous.
Well,
We're just jealous, Dr. Fitriana. We're just jealous.
I think Canada has a lot to learn, and the places where I work have even more to learn.
Yeah.
I think that Sima wanted to ask a question. Or no, you didn't raise your hand. Okay. Maybe I have a question. May I, Rin?
Yes, for sure.
It's a methodological question, Dr. Fitriana. You have adopted a pre-post research design, okay, with non-randomized control group. And for what I have read, usually when people have a training and there is an assessment just immediately after, you obtain a certain score, a certain results, but this result can disappear over time. When time has gone by after the educational intervention. Have you taken that into account, and you are also measuring now what is going on with the participants in your study, or is something that you didn't consider, or you think that is something that will be useful to evaluate in the next future? Okay. It's just a question related the strength, the validity and generalizability of the research design that you have adopted, pre-post vis-a-vis pre-post with continuous measure over time. doing
Yes.
that
Yes.
makes sense to you?
Yes.
Yeah. Okay.
Yes. Yes.
Thank you.
Prepose that, prepose, and then make sure that for an overtime, and after that they do it by themselves, and then I make some evaluation again like that. Yes. And now I still contact with the health district officer to make sure that the program still sustain like that.
Okay.
So still having contact each other.
So you have certain evidence that this beneficial effect of this interprofessional educational intervention still has a
Still
positive
has, yeah,
impact.
still, yeah,
Okay.
yeah,
Okay.
still
Good.
has to, yeah.
Okay. Thank you.
Yeah, because not only in primary healthcare services, but in the hospital too, they do that too, the collaborative practice.
Okay.
Yes.
Okay. Okay. Thank you. Thank you so much.
Yes.
So we have a question, Francesca, and then Poppy.
So congratulations, an excellent study. And
Thank you.
my question is related to culture. I'm curious to know if there is, well, you had a sample of participants, the majority were women, there were only 7 men. Is there anything behind this selection? I don't know if men didn't want to participate for any values or culture background that we don't know as a reader.
Yeah, about the participant, especially for the profession, that I never know about them, and we choose the participant by the primary healthcare officer. So I don't choose for the elderly. So I don't choose by myself like that. So from the choosing for the elderly is from the primary healthcare officer like that. Not from me to choose which of the elderly. I just give for the information to primary healthcare officer that this is my inclusion criteria for the participant in for elderly, and then they choose it, and I never know them before too.
Thank you.
Yeah.
Poppy, go ahead.
Okay, I'm unmuted. Thank you very much. Very, very interesting. I'm a dietitian, so I'm looking at this maybe from a little bit of a different perspective.
Yeah.
And I am highly, highly jealous of this wonderful initiative. I was kind of wondering whether or not, because this is, I think, beyond the scope of what you just presented, but if there's going to be any future longitudinal look at the differences between the intervention and control group in terms of hospitalization or development of comorbidities or any other health outcomes from, using this multidisciplinary team avenue to reverse malnutrition in these elderly patients.
Oh, do you mean the disciplinary for the participant, or?
No, in terms of the participants, if you were
Yeah.
going to track them over time and see if there are differences between the intervention and control group in terms of something very simple, just hospitalizations or time to hospitalization or some sort of health outcome other than an increase in the MNA score or an improvement in the MNA score.
Oh yeah, because the and the dietitian doing for the filling for the MNA, and they do for the anthropometric too, and they they give such of like counseling for the food services like that. And but for the standard, I mean for the like usually wondering whether or not in the participant is in the control group, they did the standard care, so not in comprehensive, so not together in one team for 5 profession, but just dietitian did their intervention by themselves like that. But in the for the like the intervention group, the dietitian do the intervention with another profession. It is not a standard, but the standard they just do just like used to like a dietitian did. So no like some discussion like that with another profession. And the training tried to comprehensive the role to make it more comprehensive, because after that we realized for the competence of each other of the profession, because it is not about the doctor is the most important or the pharmacist is the most important, but all of them is important team to provide the quality of life of for the elderly like that. And the dietitian for this is a the dietitian is a like they have the important role in this intervention for the elderly about the nutrition, because my topic is about the malnourished, because as you should know that because from the physiological from the elderly is have wider changes. So for the intake of the nutrition, it must be not not enough for them. So that's why this is not just the responsibility of the dietitian, but this is all of the profession in the healthcare services, especially in the community. And the dietitian focus on how to make the family understand related how to prepare interesting food for the elderly, how measure energy need like that.
Charo?
Is it?
Yes, I have a question, because I have participated this week in another forum in which the results of the participation in certain interventions was massively a female event. So what is the explanation that you can, if I well understood, females are most of the participants and most of the patients as well. So there is an explanation in your context that could help understand why male are not present in a significant way in this type of interventions. Because again, I repeat, it has happened in two different contexts, but the feminization is huge, and it goes beyond the percentage of male and female in their respective populations.
Yes. Why female? Yeah, because mostly based on the data statistic, the mostly elderly in Sleman district is female.
Okay.
And female is they more realizing for they need of health, so they they always go to the primary healthcare services, not only when they got illness, but sometimes they go to the primary healthcare services. They would just want to consultation, or I just want to check their blood pressure, like that. And we don't choose gender, because we have criteria inclusion and exclusion, and the most fit the criteria is female, like that.
Okay. So there is a really overrepresentation on that, but I think at the moment we should collectively think about that and what could be the implications for the health
Yes.
professions in general, this strong feminization. Okay.
Yes.
For the best and for the
Yes.
worst, because I imagine there are
Yes.
both sides. Okay.
Yes.
Thank you. Thank you for your answer.
Yes. Yes. You're welcome.
Does anyone else have any questions or comments?
Frances,
Cecilia?
I think
I
Francesca.
just,
Yeah.
yes. If anybody else has, so I'm going to ask another question. Could you expand a little bit on the role of the family? Because I saw that there is a part where there is the training, then there is the monitoring, the application in what they have learned in this context. So can you give us some little more information about the family and the role they can play?
Yeah, the role of the family, especially to support the elderly needs. So, the culture in us, the elderly not live alone, like maybe in the most in your country, so many of elderly live independently, but in my country, many elderly live with their children, their family, like that. And this is the important of the role of the family. We involve family to continue the intervention by the IPCP team, and we want that the family can be independent to give elderly care, such as how to prepare the food, and about how to support to the mentality health, like that. And when the elderly have to go to the primary healthcare services, having some health control, like that. And that's the role of the family that we explained to them. So it's really important of the family support for the quality of life of in the elderly. So how we hope that when the elderly is in a in a good health, so they can still have some activity, and maybe they can maybe can independently to fill of what they needs, like when they have some activity in the community, they have the like some group, like that. Yeah, that's it can happen if the family support them so much, like that. And family is the first line who closest with the elderly. So we hope that the program will be sustained through family involvement, like that. So we empowering the family to make this
Excellent.
program sustain like that.
And
Yes.
I get that the benefits of changes from malnutrition to healthy nutrition will have also an effect on the whole family, not only for the elderly. Because I was reading, instead of having fried chicken,
yes,
have boiled
yes,
chicken,
yes.
which is
It,
healthier.
yeah, it can be benefit for the family too,
Yes.
because yeah, like me that we will grow older than now. So when we learn from the one of our family member, so we can make this from the prevention for us. So that the benefit for the family when we when we teach them how to manage the elderly and everything about the food, about their health, for the medical check up like that. So the family can learn for the prevention. So we hope that after the learning, they have they have a quality of their life after it, like that. And because in Indonesia, mostly elderly living with their family, every daily life is with the family, it will give benefit all of the family, like that. So because in Indonesia, like me, I live with my father and my mom, and my father has a post-stroke and he has a Parkinson, and that my mother, she has a hypertension, like that. So I can learning from them too. That's for the example. So it make us to examine the prevention. That's the simple thing of the, we empowering the community to realize some the health is really expensive if we do not care it so much, like that.
Thank you.
Yes.
Thank you. I don't know if we have time for maybe one more question.
Yeah,
Dr.
there
Jarvis?
is a very interesting comment from Dr. Jarvis on the chat. Would you like to read it? Go ahead.
Yeah. So Dr. Jarvis was saying, I was curious about the education level of the participants. And Fitriana, do you think you would see the same result if the group of participants had a higher level of education?
Pardon me? Sorry.
No, that's okay. Yeah, so the education level of the participants, do you think you would see the same results if they had been more educated, like if they had, if they had higher levels of education, the participants? Yeah.
Yeah, because for the participant have the higher education, so yeah, I hope that they can get more of that, like that. And the participant for the team who make some the information for the elderly, the education level of the participant of these elderly mostly not have degree, so they don't have any chance to get school, like that.
I was just sorry. I'll add to my question. I was just curious well, I was curious because the education level of, like, I think more than 90% of your participants was only elementary school as the highest level. So I was just thinking more like, I wonder if information about diet, like dietary information often gets taught in schools. And I just wonder if you had participants that got through high school, if the impact would have been less. But I mean, it'd be interesting. It may not be possible with the population you're working with because they may just not have had access to education. But it could be interesting moving forward to see if the impact decreases with the prior education increasing.
Yes.
Of participants.
Yes. Yeah, that's why that we own for family to help elderly understand. We teach the family, and the family will do that to their parents or their elderly. And because it's impossible if we only educate the elderly, we have to educate the family who support. Yeah, the family is the first line that I told you before, and so that we have to educate the family for how to care the elderly like that.
Could be interesting.
So the family is the important of
yeah.
the important key for for increasing the quality of life of the elderly.
It might have been interesting to actually also know the educational level of the family, like the other people, because as you're saying, you're educating not only the elderly, but the family, and you're probably educating both groups, but it would have been interesting to see also the education level of like the primary caregiver or somebody else. That could have been very interesting too. Anyway, thank you very much.
You're welcome.
Okay, Rim, would you like to say something?
Yeah, no, thank you. So thank you so much, Dr. Fitriana, for this great presentation. Congratulations on your award. Very well deserved. Very exciting project. Very exciting study design. And thank you everyone for your questions and for the very engaging discussion. And I think we'll end there, Charles.
Yes, I would like just to add that when I was preparing this presentation with Dr. Fitriana, when we finished, she said to me, you know, Dr. Charo, because she calls me Dr. Charo. To me, to give this presentation is a dream come true, because I have been reading articles and works from written and developed by people from McGill, and to me, to be invited to give a presentation to release a dream come true. So I'm very happy that the attendance of this seminar, but we help you to make your dream come true. Thank you very much. Thank you.
Thank you so much.
Bye bye.
Thank you, Professor. Bye bye.
Bye bye.
Thank you.